Good day, everyone. We are Group 1, and today we will be presenting our case for today. It is a case of Anna, who is a 29-year-old gravida 2 para 11001, 12 weeks age of gestation, with findings of cervical intraepithelial neoplasia 2 on pap smear. Anna has stable vital signs with no signs of premature uterine contractions. Before we answer what is the best management for Anna during the course of her pregnancy, let us first identify the salient features of the case. So the patient is 29 years old, gravida 2 para 11001, currently at 12 weeks age of gestation with stable vital signs, no premature uterine contractions with an abnormal pap smear result of CIN2.
During pregnancy, the cervix becomes larger, the blood supply is increased, and decidual changes in the epithelium can be confused with cervical intraepithelial neoplasia or CIN. First in the diagnostics is cell cytology with the use of cytobrush for the collection of pap smear. It is widely accepted and recommended as safe in pregnancy. The results would be either ASCUS or atypical squamous cell of undetermined significance, LCIL, which is low-grade squamous intraepithelial lesion, or HCIL, which is high-grade squamous intraepithelial lesion. Now, patients with ASCUS should get HPV testing, and if positive, colposcopy should be done, shown in picture B. If results showed LCIL or HCIL, colposcopy is the preferred next step. So what is colposcopy? It is done using a low-power binocular microscope with powerful light source that is used to carefully examine the cervix. But before that, a dilute acetic acid about 3 to 5% concentration is applied to the cervix, and observation will be done after 30 to 60 seconds. The acetic acid will dehydrate the normal cells, while the dysplastic cells with large nuclei will reflect light and appear white, surrounded by capillaries, making a starry sky appearance. Then the next step to perform is cervical biopsy of the white lesions noted. However, biopsy should only be performed if there is suspicion of invasive disease. Now, cervical biopsy or cone biopsy or conization is done by removing a cone-shaped portion of the cervix encompassing the transformation zone and suspicious cervical lesions that is for subsequent histological analysis. The procedure is considered therapeutic and diagnostic if all cervical dysplastic lesions are contained within the specimen. However, this should not be done during pregnancy due to the risk of excessive and uncontrollable bleeding from the hyperemic and congested cervix. Now, if CIN2 or 3 is diagnosed, examination during pregnancy is surveillance, colposcopy, and cytology, and is preferred to be done every 12 to 24 weeks. But further colposcopy is accepted to be delayed until the postpartum period, since the treatment for CIN2 or 3 during pregnancy is not recommended.
Routine antepartum testing is done throughout the pregnancy of someone with CIN, like Anna. So that includes complete blood count with platelet count, urinalysis, pap smear, ultrasound, blood pressure monitoring, fasting blood glucose and 75 grams of GTT, VDRL, syphilis and HIV screening, hepatitis B surface antigen and rubella IgG testing, and congenital anomaly scan. It's important for the patient to have regular prenatal visits every 4 weeks until the end of the second trimester, and every 2 weeks from around 28 to 36 weeks AOG, and weekly visits from 36 weeks until delivery. Ultrasound scans for fetal growth and anatomy assessment are done, especially before, after, and while undergoing treatment.
Now let's go to the risk factors and complications of our patient. Anna had her second pregnancy at 29 years old. Although cervical cancer is most commonly diagnosed between ages 35 to 44, it was stated in a study that younger mothers and those with higher priority have higher rates of HPV infection, and patients of 25 years or more is one of the significant risk factors for progression or persistence of intraepithelial lesions of the cervix in the postpartum period. Another risk factor is HPV infection. All cases of cervical cancer are caused by persistent infection with high risk types of HPV. HPV is the most common STI, and it is estimated that approximately 80% of women will be infected with HPV at some point in their lifetime. Women who have compromised immune system from any cause, genetic, iatrogenic, or infectious, like increased number of sexual partners, have a greater risk of developing persistent HPV infection. Other risk factors include smoking and oral contraceptive use. The expected complications of our patient could be preterm birth and placental abnormalities.
Now, let us discuss the best management for Anna during the course of her pregnancy, labor, delivery, and postpartum. So, first, with the course of her pregnancy, we have to have close monitoring throughout her pregnancy with regular prenatal checkups because this is essential to monitor both the progress of the pregnancy and the status of the cervical intraepithelial neoplasia 2 or CIN2. This allows for early detection of any complications and timely intervention. Second, there should be referral to a gynecologic oncologist for further evaluation and management of CIN2 because CIN2 represents a precancerous condition of the cervix. And referring Anna to a gynecologic oncologist ensures that she receives specialized care and appropriate management for her condition. Third is to discuss risk and benefits of treatment options for CIN2 during pregnancy, such as cervical conization or close surveillance, because treatment options for CIN2 during pregnancy need to be carefully considered due to the potential risk to the developing fetus. And a thorough discussion of the risks and benefits of the various treatment options, such as cervical conization or close surveillance, allows Anna to make an informed decision about her care. And lastly is to monitor cervical length with transvaginal ultrasound to assess for signs of cervical insufficiency. This could lead to preterm birth, and early detection allows for intervention such as cervical cerclage to help prevent preterm labor. On the course of her labor, we have to first educate Anna about signs and symptoms of preterm labor and instruct her to report any concerns promptly, because early detection and intervention can help prevent preterm birth and its associated complications. Consider also to have cervical cerclage if there are signs of cervical shortening or history of preterm birth, because cervical cerclage may be indicated in cases where there are signs of cervical shortening or a history of preterm birth to reduce the risk of preterm labor. And lastly, there should be continuous fetal monitoring during labor because this allows for early detection for any signs of fetal distress, enabling timely intervention to ensure the well being of the baby. On the course of her delivery, vaginal delivery can be done if there are no contraindications, because vaginal delivery is typically preferred as it is associated with fewer complications compared to cesarean delivery. And women with histologically confirmed CIN from biopsy during pregnancy are allowed to deliver vaginally. Further evaluation is actually planned at least 4 weeks postpartum. Alternatively, for clinical findings with higher cancer risk, there should be repeat colposcopy and cytology or HPV testing that can be performed at intervals no more than frequently than 12 weeks. And biopsy is also repeated only if a lesion appears worse or invasive cancer is already suspected. For the course of her postpartum, there should be follow up with a gynecologic oncologist for further management of CIN2 because it is important to assess the status of the CIN2 and to determine if any further treatment or surveillance is necessary. And lastly, we have to encourage Anna to attend postpartum checkups for cervical screening and ongoing monitoring of CIN2 because regular postpartum checkups are essential for monitoring Anna's cervical health and ensuring that any changes in the CIN2 are promptly addressed. This helps reduce the risk of cervical cancer in the future.
After delivery of her baby, we need to counsel Anna on the importance of surveillance and follow up since women with a history of CIN2 or 3 are more likely to develop another lesion in the future. Colposcopy is recommended for Anna no earlier than 4 weeks after her delivery. If a lesion is detected postpartum, the guidelines state that she can undergo excisional procedures as treatment or undergo a full diagnostic evaluation, which includes cervical cytology, HPV testing, and biopsy. If there is no lesion, it is still recommended that she undergo the full diagnostic evaluation. We also have to encourage her that she needs to follow a long term follow up for at least 25 years. If Anna is still desirous of a next pregnancy, she can still conceive since pregnancy does not negatively affect cervical cancer prognosis and that survival outcomes are similar for pregnant and non pregnant women, provided that she submits herself to constant checkups, follow up testing during the pregnancy, and that she is also made aware of the risks that could ensue, such as preterm birth during the pregnancy. She may also want to submit her children to HPV screening and receive vaccinations if her children are of age already. And she herself may also still benefit from an HPV vaccination, especially against other HPV serotypes. That is all for our case. Thank you for your kind attention.